So I'll go through a couple of different aspects of hypertension, sort of a potpourri, if you will, of hypertension. Here are my relationships. So what I'd like you to leave with is to understand the epidemiology of hypertension and the recent improvements in blood pressure control rates for hypertension. I'll summarize the recent hypertension guidelines, which are undergoing change right now, dealing with blood pressure goals recommended to improve cardiovascular and renal outcomes in those with hypertension. I'll recognize which classes of antihypertensive agents are recommended as first-line agents in the treatment of hypertension. And then I'm going to talk a little bit about resistant hypertension, hypertension 202, not hypertension 101, for those of you that see these patients on 3 or more antihypertensives, one of which is a thiazide-type diuretic, and they're not controlled. And you ask yourself, well, what should I do? Okay. So let's first talk a little bit about the epidemiology of hypertension and where we've been. So just to give you a little background, there's about 80 million Americans, or 1 out of 3 adult U.S. Americans, have hypertension. Looking into this room, clearly there are people that have the disease in this room and are being treated for the disease. Because we're all over 20 years of age and older. Approximately 70% of people have a first heart attack of those with hypertension, 77% of those who have a first stroke, and 74% of those who have heart failure have blood pressures greater than 140/90 before those other diagnoses are made. And clearly there's tremendous evidence of benefit when we control blood pressure to less than 140/90. It contributes to about 360,000 deaths every year, and poor medication adherence is a major barrier to effective blood pressure control. Only about 57% of our patients remain adherent to their blood pressure medication at 2 years of follow-up, and subsequently hypertension is associated with a shorter overall life expectancy. So we'll talk about some of these challenges as we go through the slide set. So this is a nice snapshot from 1988 to 2008, looking at the National Health and Nutrition Examination Survey, looking at the prevalence of hypertension, how aware our patients are of having hypertension, are they on treatment for their hypertension? If they are on treatment, are they controlled? Or, to the far right, overall control rates of hypertension. And as you can see, in general, the prevalence is a little bit increased over the last 10 years up to 2008 from the first 10 years. More of our patients are aware of their having hypertension. More of our patients are being treated for their hypertension. And although we say that the control rates are about 50, and most recently 54% overall, this is mainly because many of our patients are not aware of their having hypertension, and they don't get to a clinician to be treated for their hypertension. Of those that are coming to our practices, we're almost at 70% up to 2008. So we are seeing these patients, we are following these patients. About 30% of our patients are not being treated to the minimum goal of less than 140 over less than 90. And if you were to do an EMR search under your ICD-9 codes for hypertension and just look at how many N's you have in that data set and look at those that have blood pressures of greater than or equal to 140/90, you could tell in your own practice what percent are not effectively controlled. Now, when you look at different ethnicities, and I just put this in from a recent paper published, you can see that from the total population in blue, the Caucasian, non-Hispanic white in red, the black in green, and the Hispanic in purple, if you will, you can see that the control rates, as I said, most recently overall are 54%. But of course, I'm not showing you those that are effectively being seen and treated. This is overall 54%. And you can see that different ethnicities have worse control rates. And that includes both the black and the Hispanic populations. However, if you look at a capitated healthcare system like Kaiser, in which they have patients enrolled and they are challenged with getting people controlled, you can see that their control rates are now most recently at 80%. And actually, in some of their populations, I'll show you in a second, it's even better. Now, why are they able to control blood pressure so much more effectively than the rest of our communities? Well, first of all, they have an enrolled population in this healthcare system, like the VA, where control rates are also at about 75 to 80%. They have a fixed formulary. They have availability of their citizens in the healthcare environment to be seen and to get their medicines. They have an EMR and a working group of clinicians, including PharmDs, nurses, telephone triage, telephone calls, where everything is linked. So the whole healthcare system is challenged with just reducing disease, because in the end, this healthcare system will be paying more for it. So you see that it can be done. Now, what's interesting about Kaiser is their algorithm. And I'm not saying that I necessarily agree with it, but it does make some intuitive sense. First, in general, they're going to start with an ACE inhibitor and a thiazide diuretic, and they use lisinopril HCTZ on the far upper left. What's interesting about this algorithm is that you'll see that they actually go to 20-25 lisinopril hydrochlorothiazide at 2 tablets a day. So they're actually using the 50 milligrams of hydrochlorothiazide that very few of you will use. And I'll show you why that may be helpful later when we talk about the thiazide-type diuretics. If they are pregnant or of childbearing age and they're concerned about pregnancy, they may use other thiazide diuretics without an ACE or RAS blocker. But in general, most patients are going to be placed on lisinopril hydrochlorothiazide. If they're then not controlled, they're going to add the CCB amlodipine to a maximum dose of 10 milligrams once a day. And then if they are adherent to their medicine and resistant at that point, and I'll talk about resistance at the end, they either have a beta blocker added or spironolactone. And in my own practice, I really love the addition of spironolactone as a fourth drug on top of the 3 other drugs already mentioned: RAS blocker, thiazide diuretic, CCB, in no particular order. And we'll talk about some of these issues in a couple of minutes. And they use spironolactone starting at 12.5 going to 25. They use Atenolol. I would tell you that I like Atenolol BID. I don't like it being used once a day, so I kind of disagree with this. There are many cost-effective beta blockers out on the market, non-traditional beta blockers, and just for an example would be a drug like Carvedilol, given BID in hypertension. Okay. And there's their blood pressure goal, less than 140 over less than 90. Okay. Now, in a more recent publication from the same Kaiser group, but this is in Southern and not Northern California, just take a look. They're up to 85% blood pressure control, but every ethnicity, every demographic going clockwise from the non-Hispanic white, the Hispanic, the Black, the Asian Pacific Islander, and others. They're all very, very well controlled. So one needs to think about what it is about this healthcare system that allows patients to be so effectively controlled, and what it is about our practice, our system approach to hypertension that doesn't allow us to get blood pressure control. For instance, you see a patient, you write a prescription, you give them the prescription, or you e-script the prescription to the pharmacist. If the patient doesn't show up within 2 days, and certainly by 7 days, that prescription is taken off the shelf. But does your office get called by that pharmacy that the patient never showed up? Possibly not. So you're seeing the patient not in a month, not in 3 months, hopefully sometime, but maybe in 6 months. Well, this has been 6 months that this patient has not been taking the medication. These are some of the issues that in a non-capitated communicative healthcare system, things fall through the cracks. Okay. Second thing, well, let's look at some of the guidelines and the goals. So first, it all starts with the blood pressure measurement. I can't tell you how important this is. And when you see on Sunday how we took blood pressures in the SPRINT trial and how this needs to be exported into our practices, you'll see how important it is that it all starts with the measurement. And in general, we believe that in your practice, you're probably looking at 5 to 10 millimeter systolic blood pressure elevations, false elevations, in what you believe the pressure to be to what the pressure actually is. So we believe that you should preferably take the blood pressure before you ever see the patient. Set up your office so that can occur, because there is a white coat effect. There is an anxiety, an alert reaction to the patient who sees us. The patient should be seated for at least 5 minutes of rest before their blood pressure is taken, with no conversation between the patient and any healthcare professional. They're seated comfortably with their feet on the floor, not on the table, not with the unit usually mounted on the wall, which often doesn't allow them to be seated comfortably on the floor. Their arms should be supported and at heart level. You should designate the arm that has had higher blood pressures in the past. So perhaps some patients will be left-handed blood pressure detection, some right-handed, but the first time you see them, you will determine which arm had the higher pressure, and you'll use that for all future measurements. And they should have no tobacco or caffeine for 30 minutes before the blood pressure is taken. We like to take 2 to 3 seated readings, feet on the floor, averaged. Some people throw out the first reading, which almost invariably is a higher reading than the next 2. Others like to average all 3. And of course, once they're on therapy, but even when you first see them, I think you should make sure they're not orthostatic, and an upright reading, usually 1 to 3 minutes after they're upright, should be taken. And that's a debatable point. Should it be at 1 minute or 3 minutes? Whatever it is, do it all the time in that patient at that duration as they're standing upright. There are a lot of problems here with this clinician measuring the blood pressure. He says, I'm going to take your blood pressure, so try to relax and not think about what a high reading might mean for your chances of living a long, healthy life. So what's wrong with this? Well, first of all, he's talking to the patient. I don't even want him in the room. I want the offices set up so that patients can come in, check in. They should really come in 10 minutes before 15 minutes before their scheduled appointment, and their vital signs can all be done. It doesn't matter if you're an ophthalmologist, a dermatologist, an orthopedic surgeon. Everyone should be getting their vital signs. It may be the only place in the healthcare system where a 42-year-old African-American male may get their health care, because they don't need a mammogram, they don't need a pelvic exam. And unless we can get these measurements, we may not know that they have hypertension. So he's talking to the patient. It's mounted on the wall, which means he has to have the patient elevated as opposed to a unit that's on the floor. She's startled, talking back. Her feet are off the floor. All of these things are going to elevate her pressure. She's pushing off on the table because she's a little anxious. The cuff is too narrow. You need to have the appropriate size cuff. So most detection devices should have interchangeable cuff widths so that you can use the appropriate cuff width. So those are all issues to be done. And believe it or not, as much as I love a stethoscope and a sphygmomanometer on the patient, we believe that oscillometric devices are what should be used for the detection of blood pressure. So no particular model, but a good model, a standardized model, and you can see this on the web under blood pressure monitors, www, and we use oscillometric devices in our clinical trials. Now, why is that? Well, in ALLHAT, we had 497 centers with PIs and nurses all involved in the care. Can you imagine if we would have gotten all these blood pressure measurements by people with different deflation speeds, different hearing, different Korotkov measurements and what they hear, et cetera. So what do? We use an oscillometric device because it's standardized, it's reliable, and it's something that I think we should be using in our practices. Which is the best measurement? Now, this is where the government is myopic, because the government believes that you're only as good as your last measurement in the office. And I can show you from this Syst-Eur trial, a double-blind randomized trial in Europe that compared initial therapy with a long-acting dihydropyridine versus placebo, a very well-controlled trial looking at 22-year data, 24-month data, and looking at outcomes, and showing that both for a systolic of 150, but also very high systolics, that conventional office blood pressure correlates least with target organ disease or end organ diagnoses. And as you go from blue to yellow to green to purple, if you will, you can see that Daytime out-of-office measurement is better than office measurement. 24-hour ambulatory is better than both of those. And nighttime within 24-hour measurement, looking for the dip, is very important as well. So we will talk about this on Sunday when I tell you that the United States Public Service Task Force has just recommended ambulatory blood pressure monitoring as a level A level of evidence for all newly diagnosed hypertensives. 24-hour ABPM before we start them on medication, because of the tremendous variability in these blood pressures, because there's a large white coat effect. And I know this is a shock to some of you, and we're not sure how we're going to export this or if it's going to be accepted by the payers. But I can tell you, we would do best technologically from the evidence base if we all had an ABPM in our offices, not only for the resistant hypertensive, but for the diagnosis of hypertension. Okay. This is the Joint National Committee's 7th report. We'll see what the updated guidelines at the end of 2016 from the American College of Cardiology, American Heart Association will say. But currently, we still say pre-hypertension is 120 to 139 over 80 to 89. Hypertension has 2 stages. Stage 1, 140 to 159, or 90 to 99. So you may have isolated stage 1 systolic hypertension, combined hypertension, or isolated diastolic stage 1 hypertension, which is most common in young and adolescent people, which has never been studied in a clinical trial. But if you observe them in the Framingham Heart Study shows these young people are at risk with isolated diastolic hypertension. Stage 2 hypertension has greater risk, easier to show in fewer people the benefits of treating this stage of hypertension, and it's defined as 160 over 100 or greater, be it stage 2 isolated systolic, when the diastolic is always less than 90, or isolated diastolic hypertension stage 2, or combined, which is the most common, where both the systolic and the diastolic are elevated. Okay. This is where we've been from Elliot Richardson, who was the Secretary of Education, which Health and Human Services, morphed over the years to Health and Human Services, originally was under. And you can see on the bottom of the slide how many more drugs we have, and that we've had these Joint National Committee reports. These were government-sponsored, vetted reports, where after the report had its penultimate document, it was vetted to all the societies that everyone in this room is a member of, be it a nurses society, a physician assistant society, a clinician society, be it family medicine, internal medicine, and all the other groups that are involved in cardiovascular disease, except for the 8th report. This was not vetted, and this is one of the issues about this 8th report on hypertension. So how did this come about? Well, the National Heart, Lung, Blood Institute originally commissioned this group, which morphed into JNC8 in 2008 to develop this guideline. And then in the middle and almost at the end, they said, we're getting out of the guideline business. We are not developing a guideline. We're going to let the American College of Cardiology, the American Heart Association, develop this guideline, and we're pulling the rug from under the carpet from under their feet, and we are not supporting this, quote, 8th report on hypertension. Well, this writing panel was almost complete. They had their manuscript. They were ready to go. And so what they did was they went rogue before they vetted it, like all the other 7 earlier reports were vetted, to all the societies. And over about 3 months, just like the United States Public Service Task Force, all of us can respond to their recommendation. Do we agree with their level of evidence? Do we have concerns? Well, JNC8 didn't have that process. So the 17 people in the 8th report went directly to JAMA and said, here's our report, and we are ready to go to print. And JAMA said, we will take it gladly. So there is a lot of controversy because some of the things they said was different than what earlier reports had said. So Fourth bullet, accordingly, JNC8 was not endorsed or vetted by any other group as previous JNC reports had been. And so we are going to have a new guideline which will take the SPRINT trial into account at the end of 2016. From what I hear from the chairman of that group, I don't think it's going to be ready early 2016, possibly the middle, but I think more likely at the end of 2016. So I don't think you have any rush to take the results of the SPRINT trial and make sure you incorporate it in your practice, because I think the dust is still settling on what the best blood pressure will end up being in our patients with hypertension. So just remember that. But one thing I do say, if you're a rigid individual and are not willing to change because yesterday's evidence is no longer today's evidence, you could have a problem in today's medicine because things are changing so rapidly. You just have to evolve. Look at the evidence, see if it's practical for your patients, and if so, perhaps that's the best way to treat the patient. But this is the 8th report, and it had 4 variables that all of us should ask ourselves as we approach all patients with hypertension. In their report, was the patient 60 years of age or older? And that's how they determined older in hypertension, which I think is a mistake. Chronological age has very little to do with how we should approach our patients. The frailty of the patient is more important. Do they have chronic kidney disease? Do they have diabetes? And are they African American? These are the 4 essential questions I think we should all ask. What I really want to concentrate on is the goal. We'll talk about the initial agents, but let's talk about the goal. What is the evidence for the best goal for improving vascular and kidney disease outcome? In JNC7, which was a surprise to many, it was not less than 140 over less than 90 for all, but in those with diabetes and chronic kidney disease, it was less than 130 over less than 80. That is no longer the goal currently being used or the metric that you are all being held to. In fact, after lifestyle modification, which is very important, including salt restriction, especially in the African American, the diabetic, the elderly, and those with chronic kidney disease, alcohol restriction, a little alcohol is better than none or a lot. Even in the hypertensive, the epidemiology is that 5 ounces of wine, 12 ounces of beer, and 1 ounce of heavy liquor is fine if you have hypertension. The problem is our patients lie. They lie. They conceal. We call it truth concealment. They conceal the truth on taking their medicine. Yes, they do. And they conceal the truth on how much they drink. So that's an issue for you to work out. But the evidence does suggest that a little bit of alcohol is beneficial. Exercise is awesome, independent of weight loss, and weight loss is awesome in blood pressure control. So both are helpful. Exercise, independent or on top of weight loss, very important. So salt restriction, alcohol, just a little, exercise, aerobic exercise, and weight reduction, all very, very important. Okay. You're 18 years of age, you're diagnosed with hypertension. If you are less than 60 in this report, even with diabetes or chronic kidney disease, the goal is less than 140 over less than 90. So to me, the sweet spot's 130 to 139 over 80 to 89. If every one of your patients in your ICD mapping has a blood pressure between 130 and 139 over 80 to 89, you are just doing awesome, because you're really decreasing their burden of stroke, heart attack, heart failure, kidney disease, peripheral vascular disease, and death. And when you take someone from 164 to 144, even if you have trouble getting them less than 140, you've done them tremendous good, because stage 2 hypertension has so much greater of a risk than stage 1 hypertension. If you can get them less than 140, great. But if they're having side effects on every class of drug you've tried, which in the oldest of the old may occur, well, you gotta, hold pat. You gotta do the best you can. First, do no harm. Okay. Where this was controversial was on the far left, in those 60 years of age and older, where based on clinical trial evidence, they said the goal should be sweet spot 140 to 149 over 80 to 89. And I just want to concentrate on that for a little bit, because I'll show you on Sunday that in the SPRINT trial, We had 28% of patients 75 years of age and older, and they did just fine with the lowest blood pressure. So stay put on how this evolves, but let's just look at this. Why did this group of 17 say originally that instead of less than 140 over less than 90, it should be less than 150 over less than 90? Because if you look at the major trials that they looked at, well-designed, double-blind, some placebo-controlled trials, they found that in high stage 2 hypertension, which often was systolic only, SHEP, Syst-Eur, Syst-China, as opposed to the HIVET, getting the blood pressure between less than 150, but not less than 140, which was achieved, with a change in blood pressure between placebo versus active of 12 over 4 from 155 to 143 in SHEP, from 162 to 152 in Syst-Eur, from 158 to 150 in Syst-China, from 159 to 144, but not less than 140. The benefit in cardiovascular endpoints on the far right was statistically significant and clinically impactful. So even though you weren't less than 140, because the delta was so much lower than what you started with high stage 2 hypertension, where their risk is so high, you translated that into tremendous benefit. So the evidence was in their favor to say it should be 140 to 149 and not 130 to 139. And we've gone through that. After the JNC8 was published in JAMA, there were 5 out of 17, even though behind the closed door they all agreed to come out with this guideline of less than 150 over less than 90. 5 of these individuals went rogue, if you will, because they were so upset that there'd be concern of letting blood pressure drift up. They published a paper in the Annals of Internal Medicine, a minority view, that no, we're sticking with less than 140 over less than 90. And unfortunately, the 2 trials that they used for their evidence base on top of SHEP, Syst-Eur, and HIVET, summarized here, did not show a benefit of less than 140. Non-significant, non-significant, non-significant. And you can see the achieved blood pressure was less than 140. Now, there were troubles with these trials in the way they were implemented and carried out. Nevertheless, and the statistical power they lost a lot of statistical power as the trial evolved because the epidemiologists had predicted more event rates than actually occurred. Nevertheless, there wasn't evidence for less than 140. So I guess if you don't like the evidence, you can give an opinion. But this is what JNCA tried to do, sort of just the facts, just the evidence. And apparently, people didn't like the evidence. They were concerned. So, in general, at the time of JNC8, we said for those 80 years of age and older, the goal should be less than 150. But in those younger, especially if they were healthy older patients, some said less than 140. JNC8 still said less than 150. Control of systolic pressure in the elderly reduces stroke, heart failure, CHD risk. And there's no age, and Sprint will show us this, there is no age where a patient is too old to be treated for their hypertension. If you can do no harm and get their blood pressure reduced, you will do them benefit regardless of their age. Most patients require 2 or more medications to get to their goal, so the first drug rarely is the final drug in the cocktail of therapy, and for the most part, a RAS blocker, Thiazide, or a RAS blocker, CCB, will do very well in all patients. We'll talk about that in a minute. Okay. A word about beta blockers. As I'll tell you in a minute, I think the first 3 drugs should be an ACE or an ARB, a Thiazide, Thiazide-like diuretic, or a CCB. Beta blockers come higher up on the list when they're post-MI within the first 2 to 3 years. Actually, the most recent guidelines suggest if you had an MI 7 years ago, and that's why you're still on a beta blocker, there's no good evidence for it. Because most of the benefit of the beta blocker is in structural remodeling within the first several years of that MI. And so for hypertension, especially in the elderly, beta blockers stack up poorly for outcomes, especially against thiazide-like diuretics. And that's what's shown here for all-cause death. What could be worse than all-cause death? And that's what's shown here for coronary disease. Diuretics are better. And for cardiovascular events, diuretics are better. All these slides are in your handout. Okay, let's move to chronic kidney disease. There's been a lot of argument about what the best goals should be in patients with CKD. Once again, on the far right, when you look at this 8th report on hypertension, some have called it JNC. Others have said this is not a JNC report. This is a rogue 8th report that this original group published. But even in chronic kidney disease, they said the sweet spot is 130 to 139 over 80 to 89, or less than 140 over less than 90. And just to summarize this, so we'll have time for questions, I want you to know the American Society of Hypertension and the International Society of Hypertension, the European Society of Hypertension and of Cardiology, and this 2014 JNC, or 2014 Hypertension Guideline, all agree that the goal should be less than 140 over less than 90, not less than 130 over less than 80. So I'm sure in your own practices, this has been relaxed so much, the bean counters are not holding you to that less than 130 over less than 80. It's less than 140 over less than 90, even in patients with chronic kidney disease. Now, the biggest problem that I have with this is that many of you are fixated on the estimated GFR of less than 60 being a measure of chronic kidney disease. In general, estimated GFRs are very reliable when the GFR calculated by the MDRD or Cockcroft-Gault formula and printed on every basic BMP that you get is less than 45 to 50. Very reliable. But from 55 to 65, it's variable and not as reliable. And so many of you think people have stage 3A CKD when their estimated GFR is 58, but then it's 62, then it's back to 57, then it's 65. If they have clinical proteinuria with that GFR, they have chronic kidney disease. And what I want you to appreciate, and I don't think I included it in this slide set, is the amount of protein, not microalbumin, but macro or clinical albuminuria, when there's 300 milligrams of albumin per gram of creatinine in a spot urine that can be sent off on any patient. You can ask for milligrams of albumin per gram of creatinine or urine, spot urine for protein. That is a very important variable, probably more important than a GFR 55 to 65. So anytime you see clinical proteinuria, regardless of the GFR, these people have chronic kidney disease. So a 22-year-old young female presents to you with hematuria in your primary care practice. When you work her up, you see that she has 1.5 grams of protein and blood. She ends up having IgA nephropathy, and she has a GFR of 110. She needs to see a nephrologist because of that clinical proteinuria, but her filtration is awesome. This is a very common scenario for IgA nephropathy. So you must take into account the GFR, which is often variable and not as reliable when it's 55 to 65, and the amount of clinical protein that you can get on a spot urine protein when you evaluate people for chronic kidney disease. Okay. Diabetes. We no longer hold you to less than 130 over less than 80, as in JNC7. This was an opinion by a linear regression analysis of what renal function did over time with various blood pressures that were observed in clinical trials. But it wasn't a double-blind randomized trial. In fact, in the ACCORD trial, we could not show that less than 120 was a better blood pressure for the primary outcome than less than 140. So what's recommended in this 8th report? Less than 140 over less than 90 in diabetes, type 1 and type 2, for blood pressure, and this is an expert opinion. Expert opinion. The ADA will come out next month with their 2016 recommendations. I think it'll be the same. It'll say that people with diabetes and hypertension should be treated to a systolic goal less than 140, the sweet spot 130 to 139. Lower systolics can be achieved. Talk to the patient. individualize the therapy. If they have proteinuria, certainly you might want to go lower, although that's still a debatable point, so that's expert opinion, level of evidence C. Patients with diabetes should be treated to a diastolic less than 90, so it's less than 140, less than 90, although you can individualize, and this is exactly what this 8th report said. So here are the recommendations. No one is saying less than 130. Most are saying less than 140 over less than 90, and the ADA says you can individualize. If you want to go lower and cause no harm, they're not against it. But they're saying at a minimum less than 140 over less than 90. Okay. Those are the goals. We'll talk more about this on Sunday. First drug. What should be your first drug? If there's nothing else you remember from this talk, this is what I want you to remember. The first 3 drugs, antihypertensive medications that should be used in the treatment of hypertension, in no particular order, should be a thiazide-like diuretic, a calcium channel blocker, and a RAS blocker. And I know that many of you, if you were in your sample closet and had hypertension, would reach for a RAS blocker as the first drug. Because in your heart you believe, how can a RAS blocker not be better? But the reality is it's all about blood pressure. And if you're African American or female, you will do better on a thiazide diuretic or a CCB than a RAS blocker. Now, if you have a compelling reason for a RAS blocker, I'm all in favor of it. And most of us need 2 drugs anyway, so you're going to use a RAS with a diuretic or a RAS with a CCB. But why would clonidine be one of your first 3 drugs? Why would a beta blocker be one of your first 3 drugs? Tachycardia, thyroid disease, okay. Post-MI, heart failure with reduced EF, okay. But I get referrals for resistant hypertension on a beta blocker, clonidine, and hydralazine. And it just doesn't make sense to me. These are $4 classes of drugs. So why not be on lisinopril or an ARB, and I have no dog in the fight, amlodipine. If you want to use diltiazem, I say go for it. But don't use 180, 240, or 300. I mean, 300's okay, but don't be afraid to go to 360, 480, or 540. Verapamil has a problem because if you go above 240, most older people are going to have constipation. So I like the peens, and I love amlodipine 10. I'll settle for 5, and if you can only get mama to take 2.5 because she's Imelda Marcos and gets edema with an open-toed shoe, I'm okay with that. But amlodipine is a workhorse in hypertension. It's got great outcomes. It reduces stroke. It reduces kidney disease on top of a RAS blocker, but it gives you the blood pressure reduction that reduces kidney disease. So you can't out-trump blood pressure reduction. So if your drug, as sexy as you think it is, doesn't give you as much blood pressure reduction as your comparator, it will not do as well. We've never been able to show that in a trial. So I love these 3 drugs as the first 3 drugs. You will do yourselves so much good if you consider this in your treatment. Now, if you're African American, it's recommended a CCB or a thiazide. Why? Because in all HAT, blacks had 40% less stroke on chlorthalidone, a 19% less stroke on amlodipine than lisinopril, because their systolic was 4 millimeter higher on lisinopril than chlorthalidone. And that 4 millimeter of difference in blood pressure translated into worse stroke outcomes. It's all about outcomes. It's all about blood pressure reduction. So thiazides and CCBs are great in blacks. However, I would add a RAS blocker as my second drug. I have no problem with that. And if an African American or an Asian or a Native American, I don't care what your skin color is, if you have a compelling reason for a RAS blocker, use it. But in an African American, you may have to add a CCB or a thiazide to the RAS blocker to get more blood pressure reduction. Awesome. So that's how I think you should approach that. Thiazides have tremendous evidence. They reduce stroke, MI, LVH, surprising to you, but they do. In both the VA and in the TOME study, lower blood pressure, less LVH. In women especially, bone mineral density is higher on a thiazide than non-thiazide. Remember, thiazides retain calcium, loop diuretics lose calcium. So we believe that it may be associated with less fracture. Osteoporotic woman on a bisphosphonate or a denosumab, clearly thiazide should be part of their cocktail. It's kind of a 2-for-1. We don't know if it prevents dementia. I'll talk about that with the SPRINT trial on Sunday, and they're very well priced. Beta blockers should be included in the regimen if there's a compelling indication for a beta blocker. Okay, beta blockers. It's not so much that I'm down on beta blockers. I like them, but I'm very much down on Atenolol, because Atenolol as a once-a-day drug is the devil's doing. If you want to give it BID so that you get full 24-hour coverage, like in the UK PDS, I'm fine with it. But it's a short-acting drug that for many hours of the day, when you least are measuring it, from late afternoon till the next morning when they take it again, they're unprotected. And they probably have less dipping and higher blood pressures when they're sleeping. So I don't have a problem with metoprolol BID or long-acting metoprolol, Nadolol, you pick it. Beta blocker du jour. I like Carvedilol, it's well priced. I like Labetalol, but I can't say they're any better than the others. I just don't like Atenolol. The outcomes for other classes of drugs to the far right on this slide is better than with Atenolol once a day. Favors the other drug class. So the available evidence does not support the use of beta blockers as first-line drugs in the treatment of hypertension. Cochrane analysis. Okay, let's move on to resistant hypertension, and then we'll have some questions. So the last updated guideline in resistant hypertension was in 2008. We're going to have a new one in 2016. What's the definition? Patients you see in your practice who are uncontrolled, at 140/90 or greater, on 3 meds, one of which is a thiazide, that make sense together, not clonidine, beta blocker, and hydralazine, and that are being prescribed at the maximum dose the patient will tolerate. Okay, so if you're on 2.5 of amlodipine, 12.5 of a thiazide, and 10 milligrams of lisinopril, you're not resistant, unless every time you try to up-titrate, the patient tells you there's a reason they can't be on it. And I will tell you, you've got a very challenging situation there. There are patients that don't allow you to use drugs in them because they always have side effects. So instead of reading the PI when the pharmacist gives them the medicine, I tell the patients, look, don't read it. If you have any reason you can't take the medicine I prescribe, you call the office. We will get back with you if I don't get back with you, and we'll discuss it. But as far as I'm going to be concerned, you and I have a contract. I write the medicine, you take the medicine, unless I hear from you. If it's too expensive, you can't get it, there was a problem, you don't tolerate it, call the office. We will work with you on this. Okay. Now, how prevalent is it? It's about 1 in 8 treated hypertensives. About 13%, 1 in 8 of all of our patients in your EMRs, in your codes for hypertension, should be resistant. That is, you just search in your ICD-10 code for hypertension, it's usually 410, and you look for those on 3 or more meds who have a blood pressure of 140/90, and you'll find it's about 13–15%, hopefully, in your practice. In this important study, where almost 8,300 individuals in a Spanish registry had ABPMs measured, as part of the overall registry, every Spaniard got an ABPM. And then they went back and looked at who was on 3 medicines or more and had, in the office, blood pressures of 140/90 or higher. 12.2% on the far left met that criteria. So they are office resistant. 3 or more meds, one of which is a thiazide, on good doses, and they're not controlled in the office. And when they went back and looked at their 24-hour ABPMs, they found on the far right that 1/3 were only uncontrolled in the office. They had no burden of hypertension outside the office. This is some of the evidence that the United States Public Service Task Force is using to recommend ABPM as an initial screening test in those you think have hypertension. You're diagnosing them with hypertension. But clearly, it's a tool that has to be used in resistant hypertension. And I'll summarize how I do it a little bit later. About 2/3 had true resistant hypertension. That is, they were resistant, and they were resistant throughout the day by 24-hour criteria. The other thing that I want to impress upon you is that our patients do not take their medicines. This is a German study in patients with resistant hypertension or apparent resistant hypertension, in which the medicines they were being given had fluorometric measurement capabilities in the urine so that they could be detective qualitatively and quantitatively in the urine, a tool that we can't use in clinical practice. And when they looked at their original 375 patients who were, quote, apparently resistant, and then they maximized the doses or excluded white coat by 24-hour ABPM, they're left with less than 1/3. And then they get rid of the secondary hypertensives or those that they could just add another drug, and now they're well controlled, and they're left with 1/4 of all the patients. And then, when they looked at their adherence rates, they found that more than half were non-adherent. It didn't surprise me so much that 30% were taking absolutely no meds, but more of them were taking less than half, as if the patient decides how much antihypertensive that you write they're going to take. So we've really got to work with patients because they don't take their medicines. I'm telling you, when you have someone on my 3 medicines that I told you at good doses and you can't budge their blood pressure, they are not taking their medicine. Get them in the office, 8 o'clock in the morning, let the nurse take the first pressure, give them the medicines to them yourself, and tell them they're going to be there till 4 o'clock in the afternoon. Do your work. The nurse every 2 hours takes the pressure. You don't have to see them. Unfortunately, they could get hypotensive because they haven't been taking their medicine all the time. But you'd be amazed at what their pressure is by 2 and 4 o'clock in the afternoon. It's a poor man's test to just show you they're non-adherent because you can't measure their urine. So what I'm telling you, especially in resistant hypertension, that about half of these resistant hypertensives are because of a poor measurement, failure to take their medication, or white coat effect. Interesting. Okay. What about dietary salt? This is a small study, patients serving as their own control, in which they were on almost 3.5 antihypertensive medications, a blood pressure of 146/84, and the typical, or maybe a little lower sodium diet than most, 3 to 6 grams. And they were put on an unpalatable amount of salt, 50 millimoles per day, 1.1 grams, for a week, and then for 2 weeks crossed over to a higher sodium diet, which was 250 millimoles, all serving as their own controls. A number of measurements were made, and let me just show you what happened. In these resistant hypertensives, their mean systolic went from 150 to 130, from the high salt to the low salt diet. Nothing else was changed. Now granted, nobody in this room is going to tolerate a 50 millimole sodium diet. But the point is that if you can get a spot urine sodium and just get an idea, even on a diuretic, although better without the diuretic, of how much salt they're spilling in their urine, you'll get a feel for how much processed food and other high salt containing foods, canned soups, etc., frozen foods, cultural foods in their culture, depending on their culture, that they may be taking. Minimizing salt, especially in resistant hypertension, can be very important. This is the workup for secondary hypertension. It's a primary care workup. A TSH, plasma metanephrines and normetanephrines seated in your office, an plasma aldosterone, plasma renin level. Remember, the aldo has to be usually at least 12, if not 15. So I'm working up a guy right now that was resistant, 38-year-old white fella, has had hypertension for about 7 years, comes into the office, he's on 3 medicines, he's taking them, and he's really poorly controlled. Did a 24-hour ambulatory measurement, he's got sustained hypertension. His aldo is 38, his plasma renin is 0.1, and now, currently, his CT of the abdomen shows what looks like an aldosteronoma in the left adrenal. So we'll do plasma selective renal vein renins and aldos. We'll get him off the Spiro, which, by the way, has already lowered his blood pressure. So now I have to get him off that so I can do these selective tests. And then I'll get our surgeon to do a lap adrenalectomy. It may not cure him of his hypertension, but I'll reduce the number of meds because he has an aldosteronoma. This is unusual because most patients have bilateral adrenal hyperplasia, but I can't tell you how important spironolactone or eplerenone can be, and Spiro is $4 a day, in the fourth drug of the algorithm that I talked about earlier. The rest of the workup, for the sake of time, I don't want to go over it too much. I just will tell you that renal vascular hypertension or renal artery stenosis is very controversial now in the hypertension area because other than fibromuscular dysplasia, where we clearly can do angioplasty for cure, and these are usually younger people that have accelerated hypertension while they had hypertension. It was reasonably well controlled, and now they've just accelerated right in front of your eyes. They need a duplex ultrasound or an MRA. They may have fibromuscular disease, and they can have an intervention. But atherosclerotic renal vascular hypertension with renal artery stenosis is a very, very difficult area because we don't have good evidence for intervention. Medical therapy, lowering the blood pressure, watching the renal function, seems to be the best therapy at the present time. But this is evolving, so we'll stay tuned to see if we should intervene here. Okay. I just want to say a word about chlorthalidone. I know most of you are using hydrochlorothiazide as your thiazide du jour. What I love about chlorthalidone, it's truly very long-acting. It's a once-a-day drug. Hydrochlorothiazide is a BID drug. You will never give it BID. I know that, but you should. And in some of the original studies, it was given BID. Chlorthalidone is evidence-based for outcome improvement at 12.5 to 25. Hydrochlorothiazide is 50 to 100 milligrams. And in the 80s, we went from high-dose thiazides to low-dose thiazides. So everyone in this room is using 12.5 to 25 of hydrochlorothiazide. It comes with lisinopril. It's $4 a month. It makes a lot of sense. But the problem is, when you look at using hydrochlorothiazide at lower than higher doses, you're getting less blood pressure reduction than you would at 50. So just take that into account. In fact, when you look at hydrochlorothiazide compared to other agents at 12.5 to 25, the outcomes are not as good. And when you compare 25 of hydrochlorothiazide to 50 of hydrochlorothiazide to 25 of chlorthalidone, 50 of hydrochlorothiazide to 25 of chlorthalidone, you always get more reduction with chlorthalidone, especially at night when you want the dipping to occur, where it's significant. So I don't expect you all to start using chlorthalidone, although I know it's more evidence-based at 12.5 to 25, and I know most of you in this room, personally, if you had hypertension, would use chlorthalidone. But the way it's packaged, the way it's available currently, just remember, perhaps you could go up to 50 like Kaiser is doing, using HCTZ BID, and at a constant rate, they won't be urinating more in the middle of the night if they're not starting and stopping the medication. If they are resistant, and you just take the dose of hydrochlorothiazide on the far left and change it to chlorthalidone at the same dose, you now will have a significant improvement in blood pressure control in those that are resistant. So chlorthalidone should be preferred. Spironolactone and other drugs are awesome. I love amiloride. Now don't forget about this potassium-sparing drug, because some people have epithelial sodium channel abnormalities. This is another drug you can use, especially if the patient's hypokalemic on on chlorthalidone, and you don't want to use spironolactone. Why not? The GFR is less than 30. Perhaps you could add amiloride. So that's another trick in your bag. Spironolactone, look at the half-life of spironolactone. That's why we don't give it TID in cirrhosis or nephrosis, okay, or heart failure anymore. It's a once-a-day drug, and it's an awesome drug. And then finally, if you just take the RAS blocker or the CCB, and now in orange, give it at bedtime, when they get into bed, instead of giving all the drugs in the morning, you may have better control throughout the day, especially in the morning when you first see them and get their blood pressures. So this was done in a large registry from Spain. All they did was take one of the drugs, give them at bedtime in resistant hypertensives, much better control. So in the future, we may define resistant hypertension as an elevated blood pressure in patients fully adherent to maximally tolerated doses of multiple drug regimens, including a long-acting thiazide, chlorthalidone preferred, and a mineralocorticoid receptor antagonist like spironolactone, while on a low-salt diet. In addition, as part of their workup, patients should have a 24-hour ABPM placed on the morning after personally administering their medications to confirm true resistant and not white coat resistant or non-adherence. Emphasizing once-a-day medications, when possible, should improve adherence, even if one or more antihypertensive medications is taken at bedtime. And I think that's the best definition of resistant hypertension, and it tells us some of the things we should do in these patients to improve their control. So, resistant hypertension is increasing in prevalence. About 13 to 15% of our patients have it, 1 in 8. The mechanisms are multiple, but aldosterone excess and high dietary salt ingestion contributing to persistent intravascular fluid retention without edema appears to be an important contributing factor. Treatment is predicated upon lifestyle changes, combining agents from different classes at effective doses with effective use of diuretics, including mineralocorticoid receptor antagonists such as spironolactone. Future approval of device therapy in the U.S., haven't talked about that, to treat resistant hypertension is uncertain, not FDA approved, but stay tuned. We're still doing these studies looking at renal artery radiofrequency ablation and ultrasound ablation through the renal arteries, as well as carotid sinus stimulation. So we talked about the epidemiology, we talked about the guidelines, we talked about the classes of antihypertensives initially and the goals, and we talked a little bit about resistant hypertension. So that's what I think the landscape of hypertension is. So with that, I'll stop. I'm pretty much on time, but a little bit over maybe. If there are questions, let's take just a couple of questions, then we'll have a break. Yes?
The role of the hypertensive edematous patient for loop diuretics?
There is a role for loop diuretics in the treatment of hypertension. Loop diuretics lower blood pressure, but they're truly not antihypertensive. Thiazide diuretics are antihypertensive. They probably are potassium channel blockers working on the vascular resistance. So they truly vasodilate. Loop diuretics get rid of volume on the venous side. So if there's edema, I would use a loop diuretic. If the estimated GFR is 35 or less, you're going to have to stop the HCTZ. You can go to chlorthalidone. 30 or less, you probably need to go to a loop. But in general, please do not use a loop diuretic unless you're forced to do it, edema or bad renal function. Thiazides are antihypertensives. Yes?
Are you having luck getting an ABPM covered by third-party payers?
Not always. And in my clinic, which is a resistant hypertension clinic, a lot of patients are willing to pay for it. But I think in the future, when I show you that this is a level of evidence A guideline from the United States Public Service Task Force, the payers are going to have to decide if they're going to do it. This is a level A evidence. So I know the frustration right now where only white coat is being reimbursed at a Medicare rate of about $50 to $60. But in the future, I think you're going to be reimbursed for this. But stay tuned. It's still an issue. Yes?
Use of lyophilized individuals with kidney stones?
Yes.
You use them?
Depends on the what's in the kidney stone. But the answer is, if it's a calcium-based stone, no. If it's a uric acid stone, perhaps. So yes, those are issues, depending on. Well, no, excuse me. In a calcium stone, let me repeat that. You can use a thiazide. You can use a thiazide. Right? Yes, you can use a thiazide. Sure. And a lot of times you will. Of course, they're anti-calciuric. You wouldn't use a loop diuretic, because in hypercalcemia, you're going to use a loop diuretic to get it out into the urine. So yes, you could. Yes?
2 quick questions and a quick observation. Compare potassium losing risk between hydrochlorothiazide and chlorthalidone, which is
Greater with chlorthalidone, no question. However, since you're using it with a RAS blocker, in the studies that have been done, you're much, much less likely to get hypokalemia with a RAS chlorthalidone combination.
RAS meaning.
ACE or R. ACE or R.
What about using amiloride versus potassium when you have a risk of losing the potassium?
No problem. I like amiloride.
You like that over just starting with potassium first?
In general, yes. But let me just tell you, in general, from the studies that we've done, including SHEP, we like to keep potassium at 4 or greater. 4 or greater. In the SHEP study, those individuals on chlorthalidone that had a K of less than 4 didn't do better than placebo. Just an observation. So we like the K at 4 or greater.
Just a quick observation, it probably goes against the JNC studies. All the patients I have that are over 90 that play golf, they feel well, they don't take any medicines, their blood pressure is undetectable. I mean, we're talking under, a lot of them under 90 systolic, under 100, under 95 systolic. This is my observation. Never had a heart attack, stroke. They feel great, they think straight.
And you're actively treating them?
No, there are no medicines, but my observation is that their blood pressures are in the toilet, and the JNC studies want their blood pressure over 130, so it's contradictory.
Well, I'll tell you, you got to be very careful. When you look at, I'm sorry. You have to be careful, because when you observe healthy individuals, and people like that are the healthiest of the old, there's a difference between the blood pressures they will tolerate and when you intervene. And you change autonomic response, and you change, renin-angiotensin response and volume. So that's the difference. So I would say that, yes, many older people, and the oldest of the old, will tolerate blood pressures they've been tolerating their whole life without any intervention, sure. It's when we intervene and we drive their pressures down that we get into trouble, And that's why anyone in this room that has a blood pressure on no therapy of 115/75 is the best person to invest in for longitudinal, long-term survival. But that's not to say that we should drive everyone's pressures down to that, because when we start intervening, we get off-target effects, we get neurohormonal counter-regulatory effects, and we can get into trouble. So that's why no one in this room should think everyone should be 115/75. But when I show you a sprint, it's interesting.